Great. Welcome to our session on health and urban poverty. I'm very pleased to introduce Stacy Lindau, who will begin our discussion here. She's an MD and a master's in public policy and an associate professor of obstetrics and gynecology and in geriatrics here at the University of Chicago. Her work includes patient care, research, education, and advocacy related to the health and aging of women and underserved populations. And Stacy directs the Southside Health and Vitality Studies here at the University of Chicago and through the Urban Health Initiative, and her paper entitled Science and Service to the Health of People Living in High Poverty Communities, Institutional Influences from Academic Medicine will really outline the conceptual motivation for that study and her work to date. Thank you, Stacy.
Thank you, Kate. Thank you, Scott and Mario, for giving me the opportunity to participate in this conference. Can you hear me okay? Yeah? I think I probably have much more to learn here than I can offer to this audience. And I have to say my Harris School master's does not quite buffer me from the feeling of intimidation in a room full of PhDs who study this topic so closely. But I'm going to do my best to answer the challenge, which I think was to look at some of the institutional influences. And the institution in which I work is that of academic medicine, or the profession of medicine more broadly, on the topic of health and poverty. So I'm not an expert on the topic of institutional influences, and in fact, I don't think there's a ton of empirical research. I'm going to try to answer that question through my own experience and then give you an example from the Southside Health and Vitality Studies that is the manifestation of institutional influences in this area. I want to first acknowledge the funding for the work that I'm doing with the Southside Health and Vitality Studies, and even more importantly, acknowledge that I'm only one of many, many people both across the university and across the Southside, 34 Southside communities that are involved with the Southside Health and Vitality Studies. Our funding over the last 2 years started with seed funding from the University of Chicago Urban Health Initiative through the Medical Center, a significant investment through the Medical Center, and now includes a diversity of funders, including NIH, local foundations, private philanthropy, and we can have a topic of discussion around PepsiCo. So Detroit is from where I come. I'm third generation Detroit person, and my interest in urban issues goes back to, I think, probably my birth, and parents, grandparents, and great-grandparents who said, you know, you've been given fortune and it's your job to give something back. And in fact, I'm reminded regularly that my focus is the south side of Chicago and not Detroit. But one day, the situation in Detroit is not good, and it doesn't take an expert in poverty to recognize that. The images here are from all the cities in which I've lived, and so I think of them as my cities as much as anyone else who lives there. I show you this picture because a few weeks ago, the University of Chicago hosted something called the Urban Forum. It was the Future of the City Forum. And one of the people who spoke was a University of Chicago trained economist, Ed Glazer, who's recently published a book called Triumph of the City. And he was very effective at making a provocative statement that caused me to purchase and read the book. And that was, we should not be ashamed of poverty in our cities. And I thought it was interesting as an economist, he was commenting on shame, but and that's part of why I went and bought the book. But what he said is that cities do not make people poor. Poor people are attracted to live in cities because of the infrastructure and the opportunity that's offered. And it's an interesting hypothesis, and one that he explores more deeply. I try to reconcile that notion, the optimistic, triumphant notion of the city, and I'm an optimistic person, and I've chosen to live and raise my children in a city, with the images like these. And as a physician who spent her entire career working on the south side of Chicago at the University of Chicago Medical Center, the Friend Family Health Center, and I think many of my colleagues, feel the daily tension between the riches of the university, the tremendous expertise of the academic medical center, and the suffering in the communities that surround us. So that's part of what motivates my interest in this area. You've no doubt, we've seen some maps that look like this, and many of you have seen this exact image, but it's a picture of the 77 community areas that make up the city of Chicago, with a black line drawn around the area that we define as the south side of Chicago. And we've kind of shopped this definition around town, and nobody really has argued about not being in the south side, if their boundary doesn't include them, or being included. And this definition comes primarily from the definition of the primary service area of the University of Chicago Medical Center. I think what's important about this image is to look at the location of the University of Chicago campus and the medical center. The world-class academic medical institution is located in poverty. And this is not unique to the University of Chicago. Our peer institutions, Yale in New Haven, Columbia on the west side of Harlem, Penn in Philadelphia, are examples of world-class academic medical institutions situated in poverty. I think it's a separate discussion for which we don't have time today to think about which came first, the academic medical center or the poverty, and we of course know that in many cases it was the poverty, and it was the cheap property prices that made it possible for institutions to develop in those regions. But there's an intricate link between the work and mission of the institution of academic medicine and poverty. There's a history of science in academic medicine, as is the case, I think, with research, social science research more broadly, again using the University of Chicago as an example. Science on or in the community, the urban laboratory, but not a history of science with or in service to the community. Now that doesn't include all of the work that we do here or all of the history here. Certainly the work of the social work tradition in the School of Social Service Administration is one historical example where science was generated with community for the betterment of community. But one of the institutional influences I'm going to argue is at play right now is that there has been a call with incentives for academic medical centers to conduct their business, including their research, with community and in service to the needs of community. And academic medical centers are increasingly being evaluated on their success in doing that in order to maintain their key infrastructural sources of funding. And I think that's an important external institutional influence. It's obviously beyond the 10 minutes I have left to talk about the vast literature that links health and poverty, but let's accept as a group that the two are intricately linked, including the impoverishment of people who entered a disease with reasonable resources but become impoverished by virtue of their disease. What's the role of academic medical institutions in this equation? Well, of course, we know the role of academic medical institutions in promoting health through direct patient care, research, bringing technology to bear, advocacy, both local, regional, and national on issues of importance, both to the sustenance of the institution and hopefully to the betterment of the health of the community, and leadership both locally and the training of leaders that are then disseminated across the country or across the world to teach others the profession. And in fact, the University of Chicago, I understand, is among the top, I've heard the number, the fourth leading producer of academic physicians. So again, it's a good place to look on this question. And hopefully academic medical institutions, although it's not, as far as I can tell, in their primary mission to move the needle on poverty, hopefully academic medical institutions have a barrier to poverty or a protector against. In the case of the University of Chicago Medical Center, we're the largest employer on the south side of Chicago. We provide jobs, education opportunities, partnership opportunities, instrumental support, for example, police force, and hopefully some physicians who choose to stay locally and provide their services to the local community. Here's one argument about why the institution of academic medicine should accept responsibility for poverty. And this comes from Spencer Foreman, who's the former president and CEO of Montefiore Medical Center, Bronx, New York, a leader in academic medicine, a former president of the Council of Teaching Hospitals for the Academic Association of American Medical Colleges, who also has a strong public health background. He says that in accepting the vast amount of public support that sustains us, especially sustains the training of physician residents, we have incurred an obligation to shoulder the responsibility for society's most vulnerable members. He's not the only one to say this, but looking in contemporary literature, he's one of the strongest voices behind, I think, something of a moral argument about how the institution of academic medicine should act and why. He goes on to say, and this is from 1994, but very pertinent to the influences today, we must begin to build a body of knowledge about the community's health and create the capacity to keep it current and useful. What knowledge do we have about the health of people living on the south side of Chicago? How many people living in this region have diabetes or obesity or are really physically fit and resilient to disease? We don't have data largely to answer these questions. How do we go about designing a system of care on the south side of Chicago and knowing whether or not it works if we don't know where we start and we don't have a mechanism over time for tracking the health of the populations? And then he goes on to say the value of understanding the health of the population we serve is that we can use these data to identify needs, to target services, to teach students, to pose new questions, and to help evaluate the performance of the system in terms of the community's health and satisfaction. And this argument from 1994 is reflected in the recent healthcare legislation that requires now in the 501c3 organization that is an academic medical center or other teaching hospital to monitor the health of the population it serves in order to qualify for its tax-exempt status, another external institutional influence. And here's a different kind of argument, which is not about necessarily accepting responsibility, but owning responsibility for poverty. And there's kind of this interesting dynamic where there's an argument about the academic medical center owning poverty as an issue of relevance. And why that is also an interesting conversation. This comes from the UK, where a great deal of work has been done by Michael Marmot, Andrew Steptoe, and others, the famous Whitehall studies that show a very clear relationship between social status and health outcomes, including mortality. And the argument here is that poverty is a social construction with many dimensions, including lack of basic education, inadequate housing, social exclusion, lack of employment, environmental degradation, and low income. Each of these diminishes opportunities, limits choices, undermines hope, and each poses a threat to health. Economic indicators focus primarily on income poverty, whereas health indicators provide a measure of the multidimensional nature of poverty. Health should be the preeminent measure of the success or otherwise of development policies. And so now there's this argument that poverty should be owned by the health, the people, those of us who are working in health, and that it's the health measures that are the best indicator of the poverty of a community. So when we think about institutional influences, there are carrots and there are sticks. And you can decide for yourself as I go through these what they are. There's a health equity movement that didn't start necessarily recently, but has been a major force in terms of even how medical schools are shaping their curriculum, especially around global health and increasingly around urban health in the cities where medical schools are located. Partners in Health out of Harvard, Paul Farmer, Jim Kim, now president at Dartmouth, is just one example. And if you haven't read Mountains Beyond Mountains by Tracy Kidder, I suggest you do. It'll be your best understanding of what I mean in this point. Healthy People 2010, which was written in 2000 by the Department of Health and Human Services, has as its ultimate goal to eliminate health disparities. The Institute of Medicine, the World Health Organization, and other lead world organizations have targeted health disparities as a key area. And U.S. Public Law 106-525, passed in November 2000 under President Bill Clinton, led by Senator Ted Kennedy, established a National Center for Minority Health Disparities Research at the National Institutes of Health. All of these factors have been important in influencing where academic medical centers are going with their research. There's a push toward thinking of the health system not just as medical care, an understanding that medical care and access to care is important for health and health outcomes, but probably accounts for a minority percentage of an individual's health. Maybe 10 or 20% of an individual's health or a population health is determined by access to health care. So the idea of intersectoral health system is that medicine, academe needs to partner with business, and even media has been named, and community organizations to take responsibility and ownership for health of the population. And this concept is helping to justify new funding mechanisms for research and programming to address health. I mentioned this before, but refinancing of the academic medical center research infrastructure, primarily through something called the Clinical Translational Science Awards. I see Julian Salway here, who heads our Institute for Translational Medicine. Again, required medical institutions to demonstrate how they were partnering with communities in order to prioritize issues for research and to implement findings to better human health. And other factors are listed here, and I already mentioned the Accountable Care Act. It's also, I think, interesting to point out that there has not been an explicit call to physicians for necessarily social responsibility. The oath, the Hippocratic Oath, for example, focuses on treating slaves the same as non-slaves with respect to sexual conduct of physicians, but does not go further to talk about the role of physicians' responsibility to all members of society. In 2005, the American College of Physicians and many other physician organizations around the world stipulated that physicians have an opportunity and duty to advocate for the needs of individual patients as well as society, and they should work to ensuring access to health care for all persons. So again, there's this new theme, recent theme, that is influencing how we're spending our time and our resources. There are internal institutional influences, and I think given time, I'll leave these for question. I did not start the Urban Health Initiative. It was started under the leadership of our former dean, Jim Madera, and with the help of Michelle Obama, who has now gone on to other activities. But Michelle Obama said something important, which inspires the work that we've been doing. And what she said is, we can't do well serving these communities if we believe that we, the givers, are the only ones that are half full and that everyone we're serving is half empty. There are assets and gifts out there in communities, and our job as good servants and good leaders is not only just being humble, but it's having the ability to recognize these gifts in others and help them put them into action. And that notion that comes from her work with the Asset-Based Community Development Institute at Northwestern University has really inspired the work that we're doing with the Southside Health and Vitality Studies. I'm nearly out of time, but I want to take a moment to share with you the focus of the studies, working under the Urban Health Initiative with a vision that Chicago's South Side is a paradigm of urban health by 2025. We're using an asset-based model, which means we've invested significant resources in building relationships broadly with strong community leaders and organizations across that whole South Side region I showed you. We've been in a very methodical process of identifying all of the assets in this region, recognizing it's a low income, low resource region, and on the other hand, feeling that in order to build a system of health, we need to first know where we start. We've been mapping. We've mapped 11 communities, the ones that immediately surround the medical center. In 2009, 6 communities. In 2010, another 5 communities, and we've updated the original 6 communities, so we have longitudinal data. This shows you where we've been mapping. And this shows you, if you're interested in knowing more, the website southsidehealth.org, where all of the data we collect within a few weeks is made available to anyone with an internet connection. And the brilliance is this one, dondeestá.org. I don't know how I'm the only person in the world who thought to buy that URL, but this is the Spanish translation of the website. I'm sure it's going to make us rich, and we'll use all the revenue to reach our 2025 goal. I just want to quickly share with you, because it's such a diverse audience, these data are available to anyone who wants to use them for research purposes. They're available free to anyone with a not-for-profit intention. And it looks like it's not projecting very well, but what these are changes in assets by sector in the 6 communities that we've mapped twice. We believe that we have as close to 100% census of every single built asset in these communities. And for the first time, we're able to see, for example, in 1 year, the amount of gain and loss, say, in the public service sector. 10% loss, no gain in 1 year. When we share these data with community members, many of who've been involved in collecting the data, what they say to us is, first of all, we spent a lot of time and effort for you to tell us what we already know. And second of all, with the University of Chicago imprimatur, our policymakers and leaders are going to start listening to us when we tell them that this is what's going on in our communities. So we think these data have multi-purpose, and we hope that you'll consider working with them. I think with that, given time, I'll wrap up my talk. I want to thank you very much for the opportunity to participate, and I look forward to answering your questions. Thank you.
Thank you so much, Stacy, for that amazing overview of the Southside Health and Vitality Studies. Our next speaker is David Meltzer. David is an MD and PhD in economics, trained here at the University of Chicago. He is director of the Center for Health and the Social Sciences, and he is the chair of the section of hospital medicine at the University of Chicago. He's also chair of the Committee on Clinical and Translational Science here. He's a research associate of the National Bureau of Economic Research, member of the American Society for Clinical Investigation, and past president of the Society for Medical Decision Making. His paper is entitled Reorganizing Care for High-Cost Patients in Urban Environments, and it's a nice synergy with Stacy's work, because he's really going to draw out the training components and the institutional resources we could bring to bear for some of the questions that Stacy outlined earlier. So, thank you, David.
Great, thanks so much. It's such a pleasure to be here. As Kate said, I'm going to talk about reorganizing care for high-cost patients in urban environments. And when you talk about healthcare in the United States at a conference where you're already talking about problems, you feel bad. because when you look at the sort of big picture of US healthcare policy, it only brings a whole nother set of problems to the table. And I want to start with those to help frame the context in which we have to think about this problem. The big problem we face is that US per capita healthcare spending is sort of too high and unsustainable. And it's only going to get worse in the next few years as the long-anticipated aging of the baby boomers finally hits us. Moreover, as we spend all this money, far more than any other country in the world, we don't cover many, many people. And the reduced access to care that results from this causes worse health outcomes and inefficient spending. And so these are major problems, even with the large amount we spend. As health economists have looked at this problem, what they've come to recognize is that excess utilization and inefficient provision of care, not high prices, are the key drivers of high health spending and poor outcomes. It's just quite simply that we're doing too much and we're doing the wrong things. And when we think about why that is, the main conclusion has been that the underlying problem is fee-for-service payment. We pay doctors to do more, we don't pay them to get the outcomes that we want. And as a result, we get sort of too much care and very often the wrong care. And this is critical because it's not that we as a country spend too little on healthcare, even too little on healthcare for the poor. It's that we spend the money so poorly. We spend more than any other country, and if we could just use that money well, we would have a much healthier population. And as a result, when people have thought about healthcare reform, efficiencies from payment reform have really become a key part of this. And the whole set of demonstration projects within the Affordable Care Act sort of continue a gradual trend in this country of payment reform. From this fee-for-service system that simply pays people to do more, to the Medicare prospective payment system, which paid hospitals to care for patients over a fixed hospitalization rather than just paying more the more tests and length of stay were provided, to increasingly discussions about episode-based payment and bundling, where you pay a hospital to care for a patient through an illness, not just till they leave the hospital door, but until that illness is resolved. An increasing movement towards capitation, or this idea of accountable care organizations, where you pay a provider to care for a patient over a year, a whole period of time, and they're accountable for the outcomes of the care that is produced. This idea of moving towards an accountable care organization has implicit in it the realization that the only way we're going to reach the desired spending reductions is with real efficiency and reduced use. We have to design a more efficient healthcare system to address these problems. So the question then is, what are the opportunities for efficiency? And I'm going to focus on one in particular, which is the set of very high cost, frequently hospitalized patients. And sort of the motivation for focusing on this is that healthcare costs are known to be highly concentrated among a very small fraction of individuals. And some of you may have seen Atul Gawande's recent article about hot spotters in the New Yorker. The key thing is a very large fraction of healthcare expenditures is accounted for by a very small fraction of the population. So 93% of US healthcare expenditures accounted for by 50% of the population, 40% of all Medicare spending accounted for by 5%. On our own general medicine service here at the University of Chicago, 40% of the general medicine bed days are accounted for by 10% of the patient, 30% by only 5% of the patients. So the key thing is, if you can deal with this sort of small percent, you really have to deal with them to bring down costs. Now, when you look at these costs among high-cost users, the vast majority of these costs are really hospital costs. And so you really want to focus on how do we reduce hospitals costs, rates of hospitalization, and so on. When you look at these patients and why they're ending up in the hospital and why their costs are so high, one of the things you discover is that lack of coordination is a tremendous problem. These patients very often have multi-system organ disease, which leads to fragmentation of their care across many providers. And with increasing medical specialization, which is to some extent inevitable because of increasing knowledge, this gets much worse. The problem is it's compounded also by a payment system that rewards every doctor every time they see the patient. You don't get more money for solving several problems than you get for solving just one. This also produces tremendous problems with handoffs and miscommunication, which leads to costs and errors. And this is especially true for complex, subspecialty-oriented patients with multiple organ problems. It's also a particular problem for patients who have trouble guiding their own care, who happen often to be the sickest patients. And most recently, the system, in fact, has made it even worse with the growing use of hospitalists, who are physicians who specialize in inpatient care. And I actually run our hospitalist program at the U of C, so to tell you they're part of the problem is unusual, but they are in fact part of the problem. Because the problem is that they may be very good at caring for the patient in the hospital, but they don't know the patient, and the patient doesn't know them. And so they may do a better job right there, but what happens when they leave the hospital? And what happens with the sort of most sick patients who are frequently going in and out of the hospital without having their real underlying problems addressed sometimes? Now, all these problems are much worse of care coordination are much worse in urban populations for a whole variety of reasons. So on the left here, I have a set of drivers of poor coordination. So for example, multi-organ disease is a big problem. You need many specialists. Well, is this different in, say, an urban environment compared to a suburban environment? Probably not. Urban and suburban kidneys probably start out about the same. The thing is, they don't end up that way. And after years of neglect and progression of disease, they may be very different, and people may have many, many more organs involved as their health worsens. Moreover, there's a lot of referral of complex illness into cities, and that creates an added problem. Medical specialization is also a bigger problem in cities. Urban environments tend to have a very large specialist base due to their density and scale. You can't be a super subspecialist in a rural or even suburban area. Moreover, the culture of urban healthcare systems focuses on academic medicine and expertise, and that worsens this as well. Cities also tend to be places where people lack insurance that covers preventive care. And that leads to, with concentrated poverty and less ability to cross-subsidize across insured and uninsured people, you get a breakdown of the system in urban environments. The other problem in urban environments are the social problems. Patient and family may be critical for coordinating care, and where socioeconomic disparities are greater and lack of social support is a larger problem, this only gets worse. And then finally, a lack of integrated inpatient and outpatient care. As I mentioned, empirically, there's hospitalists are a problem, and hospitalists happen to be much more common in cities. Well, so I'm going to focus on this one component of it, the part that's most relevant for the work that I've been doing recently, which is this growth of hospitalists. And I'll say that there are sort of two basic theories as to why hospitalists have grown. One is that they've grown because they do a better job with hospital care. They reduce length of stay and cost. They're better prepared to address acutely ill patients. The challenge, of course, is this discontinuity I mentioned earlier. And the optimal use of hospitalists sort of balances these two sides. And most people would argue, well, the growth of hospitalists reflects the idea that hospitalists on net do a better job, and that's why everyone's using them. I've been doing some work funded by a grant from the Robert Wood Johnson Foundation looking at another theory, and that is that hospitalists grew not because they do a better job, but because they meet the needs of ambulatory care, and in particular the needs of ambulatory care doctors. And the basic problem is that over time, ambulatory care doctors have found it less economically attractive to see patients in the hospital. It used to be that the classic job of an ambulatory care doctor was they see patients in clinic most of the day, they admit some of them to the hospital, and then every morning they're in the hospital seeing those patients, and they see them in both places. What happened over time is that admission rates fell so much that the ambulatory care doctors were admitting only 1 or 2 patients to the hospital. And so they were making a trip to see only 1 patient. They simply didn't want to do it anymore and effectively abandoned the patients in the hospital, being left to be seen by doctors who simply didn't know them as well. With my colleague Jeanette Chung, a sociologist, we've been analyzing this issue and have developed a sort of economic model comparing this traditional model to a model with the combination of primary care physicians and hospitalists. And we've shown that this sort of change in the division of labor is driven by factors such as transport costs, communication costs, these fall in admission rates, and the fact that physicians just no longer want to work so many hours to see patients in both settings. And when you actually line up these theories with empirical data, we find evidence for every one of them. And what we're concluding from this work is that this change in the division of labor has happened not because it's better for patients, but because it's better for doctors. Okay? And so the problem is we're sort of left with this system that, the question is the use of hospitalists an economic necessity of changes in ambulatory care, but ultimately bad for patients who are hospitalized? And so what we've been thinking about now is, well, maybe the possibility of a better model, a sort of tailored approach to general medical care, where if the underlying problem is that doctors aren't seeing enough patients who are being admitted to the hospital, we could stratify patients by their expected hospital use and take the patients at low risk of hospitalization and just have them cared for by ambulatory care doctors. And in the rare instance they get cared for in the hospital, they can get a hospitalist. But then you take the high expected hospital use group, the people who are going to be frequently admitted, and give them a set of doctors who only care for patients at high risk of hospitalization, but can do it in both places. So they're admitting enough patients to the hospital that they can really be there. And this is sort of the old model, but it's actually a very brand new model because of who it focuses on. And this would have a lot of advantages. The neediest patients would get their own doctors in both settings. Their patient choice could be largely preserved. These sort of doctors could actually make enough money that their jobs would make sense. It would work with the idea of a patient-centered medical home that coordinates care. It wouldn't require an infinite division of labor in medicine, which I think is an increasing problem. It would work well under bundling and capitation because they could reduce hospitalization. And a very small primary care base could do things like fill an urban hospital that was at risk of failing. You simply build a clinic right next to the hospital and help save this dying institution. The disadvantages: would patients be willing to switch? Will doctors let their patients switch? Would doctors even do this job? Can it be economically viable? And these are some of the things that we're beginning to think about. I'll just say that this sort of innovation is exactly what healthcare reform is designed to promote. And these ideas of accountable care organizations have been adapted to think about how they would work within academic medical centers. The American Association of Medical College had a series of proposals for health innovation zones that would show that better coordinated care would help improve delivery and efficiency, and that AMCs would play a role in this. The original definition of these programs focused on AMCs caring for a defined geographic population, taking a fixed payment level that increased at a slow rate, and basically waiving a whole series of other federal regulations that would otherwise prevent these things from happening. Why does the American Association of Medical Colleges want this to happen? They want AMCs to be thought leaders. They recognize they already care for 40% of this urban, diverse, at-risk set of patients. AMCs are large group practices with the size and sophistication to maybe do this. And in fact, many of them are already engaged in innovative models of care. Now, when this was proposed a number of years ago, originally it was proposed in a piece of legislation, the Healthcare Innovation Zone Act of 2009, that began with planning grants and then would have a second stage that was a pilot program to actually implement it. This was never passed. But in the Accountable Care Act, under the Centers for Medicare and Medicaid Innovation, there's $10 billion allocated over the next decade for innovation projects. And one of the innovation projects that's been proposed as part of that is these sort of health innovation zones, in which an academic medical center would lead in an area this sort of reform. And so these are the types of discussions that are happening at academic medical centers today, including ours. So just to conclude, U.S. healthcare reform is increasingly focused on improving access and controlling costs, with payment reform and accountable care organizations really as key strategies. Controlling costs means focusing on high-cost patients, and these patients have unique characteristics in urban environments. New models of organizing physician roles to combine inpatient and outpatient care for complex patients may help address some of these challenges. And there are opportunities under healthcare reform for academic medical centers to form accountable care organizations that may provide a context for these models. I think the big question about whether this will actually happen is, can academic medical centers overcome their traditional priorities and organizational inertia to actually innovate to address these challenges? These are fundamental ways of rethinking how we organize care, and institutions don't always take on such fundamental changes so easily. And that will be one of our big challenges. So thank you.
Thank you, David, for laying out a number of important questions and proposing a new model of service delivery. We're now going to take our discussion to the level of the patient. Celeste Watkins-Hayes, PhD in sociology from Harvard University, is Associate Professor of Sociology and African American Studies at Northwestern. She's a faculty fellow at the Institute for Policy Research and director of graduate studies in the Department of African American Studies. Her research focuses on urban poverty, social policy, HIV/AIDS, and she's currently principal investigator of the Health, Hardship, and Renewal Study, which explores economic and social survival strategies of women living with HIV/AIDS. And so her paper today, Dying From to Living With, Framing Institutions and the Coping Processes of Black Women Living with HIV/AIDS, is drawn from this work.
Thank you so much. Good afternoon, everyone. I want to thank Mario and Scott for inviting me here. It's been an outstanding conference. I actually want to start my talk with two quotes. As an ethnographer, I usually give a lot of setup before I go to quotes, but I actually think that these quotes very nicely set up the point of my talk. The first quote, "I thought it was a death sentence. I started crying before the doctor even got it out, and I was distraught. I was emotionally broken down. I thought it was a death sentence. I just knew I was going to die soon. Matter of fact, after I left the hospital, I used drugs more. I was in denial. I didn't tell nobody for about 2 years." Sheila explains her reaction to the HIV diagnosis she received while hospitalized with pneumonia in 1994 at the age of 32. The news triggered a downward spiral of denial and drug abuse as she, like the majority of women that I'm going to talk about today, immediately associated HIV with physical, social, and emotional death. Consistent with previous literature, many women engaged in harmful behaviors upon receiving the news, failing to properly manage their health with medication, diet, exercise, and rest, failing to engage in regular doctor's visits, ignoring depressive symptoms, and returning to or initiating quote-unquote risky behaviors, including those that may have led to infection in the first place. A second quote, "I've accepted the fact that I have HIV. This is a part of my life. You know, I can't change it. It's my belief and I have faith that I can be healed from it. And if I'm not, it's still okay. I'm working with my position. I'm keeping myself healthy. I'm lowering my stress. It's okay. I have to get to a happy place. Therapy is what got me there. This is how your life is. Take it and move on." On the other hand, the vast majority of our respondents, while they talked about this notion of a death sentence, also offered quotes like this idea of coming to terms with their illness through a process that we call the dying from to living with process. I was really curious as to the question of, is this merely stress-related growth? Is this merely a question of someone receiving awful news about a health diagnosis and then coming to terms with that news and offering a positive spin on it? And what I want to submit to you today is actually the significance of what I call framing institutions in the lives of these women suggests that for socially marginalized groups, the adoption of healthy behaviors to fight HIV and to come to terms with one's status cannot be fully explained simply by focusing on individual resources and challenges and people's individual psychological coming to terms process, or even environmental conditions, which often are the focus of many sociologists. Rather, it must be this coping process placed within a context that is attentive to how shared knowledge, diverse social networks, and destigmatizing social spaces fostered or stymied by certain organizations prove medically and socially critical for those who often lack these resources in other areas of their lives. So the fundamental research question that this paper looks at is, how do Black women living with HIV move from beliefs and behaviors that suggest that they are dying from their illness, like the first quote that we saw, to beliefs and behaviors that suggest that they can live with HIV, like the second quote that we saw. So just to give you a preview of the argument, I'm going to argue that framing institutions are shaping the form and tenor of this coping trajectory, this dying from to living with process, by offering initial information about health status, a conceptual framework to understand the social meaning of illness, language to talk about one's condition, resources to restructure one's life post-diagnosis. Therefore, these institutions are playing a critical role in how women accept their changed health status, manage the disease symptoms and problems, and integrate HIV into their everyday lives. Perhaps most importantly, we found that women who do not rely on framing institutions are at a significant disadvantage in dealing with their HIV status. And we saw significant class differences in terms of how middle class versus low income women interacted with framing institutions and how it shaped their coping trajectories. Just to give you a little background about the HIV epidemic, at the end of 2006, over 1 million people in the US were living with HIV, with 21% undiagnosed. In 2006, that same year, we had about 20,000, a little over 20,000 people living with HIV or AIDS in the Chicago area. Blacks represented 36% of the city's population at that time, yet accounted for 58% of the diagnoses and 55% of all people living with HIV/AIDS in the city. In 2005, there were a little over 4,500 women living with HIV in the city, of whom 76% were Black, 13% Hispanic, and 9% white. And it's important to note that Black women comprised only 37% of Chicago's female population, yet they're 76% of people living with HIV that year. It's important to think about the environmental context when we talk about HIV. So often we focus on individual behaviors, and we often get distracted by debates about men on the down low, for example. But it's important to understand HIV fundamentally as a disease of inequality. When we think about the environmental factors that our respondents are facing, they're living in racially and often economically segregated neighborhoods. They're more likely to be exposed to long-term poverty due to limited education and job opportunities. They're more likely to experience lack of access or limited access to health care. And they're more likely to be exposed to mass incarceration and the drug epidemic and the health implications of those two phenomena. And Black women are the group least likely to interracially date and marry. So what we're trying to understand are what are some of the coping strategies and what are the cultural responses that women are mounting to respond to these environmental realities, such that, as I said, 37% of the female population in Chicago is Black, yet representing 76% of the HIV infection cases. How are they coping with this reality? So previous literature suggests that trajectory of dying from to living with is really about the support of friends and families and intimate partners. This actually tends to be not a critical factor in women's coping processes in our data, and I'll talk about our data set in just a second. Women rarely talked about family members and friends as being important factors in terms of helping them move along the trajectory, and part of it is because family and friends don't necessarily have the economic resources or the information about HIV to help them understand what the disease will mean for their lives. So they've got to go to experts. Of course, previous literature suggests that medical providers and other health professionals are critically important, and of course, HIV-specific support groups, legal assistance, and advocacy groups are important. But we were interested in what are the other institutions functioning in women's lives who may be playing critical roles in framing what HIV will mean for them, such that they're helping women along this coping trajectory. So this conceptual idea of the framing institution is inspired by Goffman's work and also by much of the social movement literature that thinks about framing. And we're really thinking about these institutions like all institutions, intermediaries between micro-level perceptions and actions and macro-structural forces and systems. And we're trying to think of these institutions as helping people to interpret and address both the physical realities, but also the social significance of this new life condition that is HIV. And we're interested in how these institutions facilitate a set of social interactions that prove pivotal to individuals' subsequent decision-making. Why are these institutions different from any other institution? Well, I argue that they differ from other organizations and that they help to facilitate a turning point in people's lives that represents a marked change in how they're coping and a marked change in what the strategies that they're using to cope. The data set on which this paper is based is a pilot study that I did called Sister to Sister. And in that project, I was interested in understanding the social processes and experiences of Chicago area Black identified women living with HIV. And I was interested in looking at a range of domains in the women's lives to understand how HIV impacted their daily living, their life chances, and their social outcomes. And we focused interviews by talking about the 4 social domains you see above: work and economic survival, social networks, childbearing and rearing decisions and practices, and dynamics of intimate relationships. And I've since been funded to expand the project, so now we're interviewing a racially and economically diverse group of women. We're interviewing 75 women living with HIV, really focusing on this economic and economic survival piece. And actually 2 of my research assistants are here, Elise Kowalski and Bobby Vargas worked on the project as well. But back to the pilot study. It was an ethnographic study design. It was basically three interactions minimally with each respondent. So 2 interviews and 1 observation session. And we asked women to allow us to go with them to a site where their HIV status was both known and salient. So a support group meeting, a doctor's appointment, an activist event where they were speaking about living with HIV, a social service agency visit, and it's a small group because it's an ethnographic study. 25 women who completed all of the interactions, and as I mentioned in the larger study, we've expanded it to looking at doing interviews with 75 women. And I'm currently doing follow-up interviews with the sister-to-sister group. So again, they're all self-identified actually as African American. The larger study that we're doing has black women, so not all are African American. Average age you can see is 36. 4 were diagnosed with AIDS at the time of participation in the study. The rest were HIV positive. You see the year of diagnosis, marital status, children. Importantly here, you see the very low income status of the women in the study, and that is not unusual in terms of the demographics of the epidemic. Importantly to note, all of these women had publicly subsidized health insurance that covered both their medications and their doctor's visits. So this was a very marginalized population that had Medicaid and had ADAP, which is the program for people to pay for medications living with HIV. So I want to offer up a couple of quotes that really frame and talk about how these framing institutions end up being very influential. And this is a quote from Stevie, who was diagnosed at 44 in 2001 and was diagnosed in prison. I felt so bad because I couldn't talk to nobody about it because she, and this is the nurse practitioner who diagnosed her in prison, where Stevie was tested. Don't let nothing like that get out. Don't tell anybody. And then it hurt me so bad because this other young lady was in prison and she was doing the medication cocktail. So there was another woman who was housed with Stevie whose status was known to the prisoners. Someone was like, oh man, I don't want to be by that bitch got AIDS. And then one time, the girl who was HIV positive asked someone for a cigarette, and the one she asked was like, no, you got that shit. I felt sorry for her. So individuals do not always receive information about their diagnosis from traditional medical institutions, and we see that prison ends up being a very important framing institution for Stevie. She voluntarily took the test and immediately associated HIV with shame, stigma, and the need to be silent, because part of what the nurse practitioner was doing was trying to protect her confidentiality by telling her not to say anything. But what she remembers the most about this process is you do not tell people that you're living with HIV, and as she witnessed what happened to this other woman, she understood it to be a very shameful experience. So in trying to explain to me why she avoids medication against the advice of her doctors, even outside the prison walls, Stevie still talks about that HIV positive inmate being ostracized in her experience in prison. I'm half a woman, she says, because I got something they can't cure and I can't shake. Since her diagnosis was initially framed by beliefs that she cannot live with HIV, Stevie effectively relies on what got her through 2 years of prison as an HIV positive woman, silence. She feels depressed and laments her self-imposed isolation from others, including her own family. She seems unable to figure out how to accept, productively talk about, or positively address her HIV status, demonstrating the power of a negative framing institution for someone who already struggles to cope with life's very difficult situations. In contrast, Danny says this about her diagnosis experience. Oh, the first words out of my mouth was, God's punishing me. But then my doctor said, God doesn't punish us. The doctor must have been a Christian, and he was talking to me from a Christian's point of view, and I was like, is he really telling me this? And I stopped crying because, of course, I was crying and all upset. And he said, no, God loves you. And I'm thinking, how in the world does God love me? This is so dirty. That was my biggest problem. I couldn't get clean from the inside. There's no way to get clean except God does that. So here we see a very different story about the role of institutions and institutional actors in terms of how HIV gets framed. And Danny talked about the fact that when she thinks about her ongoing coping process, she remembers this narrative of God is not punishing me, God loves me. And she keeps reiterating this throughout our interview. God loves me, God isn't punishing me. So clearly we see this contrast in terms of the initial information and the conceptual framework that framing institutions provide and the implications they have for how women therefore understand how they're supposed to manage their health status. So it's not always traditional medical providers who are framing agents. And this is the story of Jackie, who was diagnosed in 1991 She entered a spiral of drug and alcohol abuse. She had not been using prior to being diagnosed, but the diagnosis caused her to start using. She gets into an altercation with her brother-in-law, and the police come, and she ends up in the back of the police car. Then the cop says, "Now back to you. What's bugging you?" She said, "I'm HIV positive and I drink a whole lot." She said, "All right, you want some help about your drinking?" And I said, "Yes." At that point, I started crying. She said, "You really want some help? Because if you really want it, I'm going to help you." I said, "I think I need that help." So Jackie immediately was referred to a drug and alcohol rehab program, and here we see this critical link between drug and alcohol rehabilitation centers and people living with HIV, because there's often overlap in terms of diagnosis. She has this to say: "That's when I believe I came into my true acceptance of being HIV positive, because I think early on, from 91 to 99, 8 years, I kind of blocked, wiped it out. I don't think I accepted it then. It wasn't until I attended these groups, seeing women and men say they were addicts, telling their story of where they came from and how they got to where they are, that I became like a sponge, absorbing everything I heard." And I was kind of sold on the idea, because everywhere somebody raised their hand and said, "I got 2 years, I got 8 years, I got 7, and they're talking about being clean. I said, damn, this is gonna work, because everybody's coming in here clean, because after denial came into acceptance. So within the framing institutions of drug and alcohol rehab centers, which, by the way, were cited as significant places where women learned how to cope with HIV, from 15 out of our 25 respondents talked about drug and alcohol rehabilitation centers. The tools of substance abuse treatment merged with the strategies and practices to manage HIV, offering individuals both the language and resources to address their both statuses. So respondents often discuss balancing a sense of personal agency with spiritual surrender, acknowledging past mistakes, basically bringing the discourse of drug and alcohol rehab to bear as it relates to their management of HIV. In fact, women will tell you, "I have to avoid people, places, and things that may threaten my ability to take care of myself living with HIV." And that's actually language from drug and alcohol recovery. So they're taking that language that they're learning in one institution and using it to talk about their experiences with HIV. This is just a quick quote from a woman whose pastor ends up being a very influential force. And if you read the paper, which I think may be circulating, you basically see how he, in fact, acts as a framing agent. And in the interest of time, I won't go into it. But of course, women are not only thinking about taking care of themselves, but they're starting to move in the direction of becoming activists and thinking about how to become framing agents themselves, and to move themselves even further along the coping trajectory of coming to terms with their illness. So this is Jackie, who we just heard from, that then talks about, "I want to work with people who are HIV positive." And during our observation, we were in a support group where she was facilitating and she was praying with people living with HIV. But one of the most important things is the fact that she says, "I want to be a help to others," and I think that her role, therefore, is to inspire. But there's some limitations to framing institutions as I close. First of all, the coping process is a process that vacillates, right? So for the sake of clarity, and because I only have 15 minutes, I'm presenting this as a linear process. But there's a lot of back and forth, right? And there's a lot of moments in which women get stuck. And one of the things we were interested in is, what is the role of institutions in that vacillation process and in women getting stuck? And we found 3 key themes that contribute to that. First of all, women who are institutionally disconnected tended to be the women who believed that death was imminent, whether it was physical death, their emotional death, or their social death, and their desire to kind of pull back from society and not manage their HIV infections. And these tended to be women who had very troubling numbers as it relates to the progression of the virus and had their doctors concerned. Women with multiple and ongoing barriers that go unaddressed. These institutions aren't panaceas. So for women with multiple barriers, with ongoing substance abuse problems or depression or histories of sexual abuse that have not been addressed, framing institutions can only do so much. And then finally, women who minimize their interactions with organizations because they perceive poor staff quality or bad experiences around confidentiality. And confidentiality is obviously quite important to the women. And this is my last quote, where Rosalind, age 40, talks about living in a place for people, an apartment building for women living with HIV, but yet being institutionally disconnected. She doesn't use the services. She really struggles to take care of her health. She's often in the hospital with opportunistic infections. And when we talked about the level of social support she was getting, she starts talking about her environment. And she has this to say: "The executive director knows all of us. She knows our ups and downs because she interacts with us. She's caring. But the rest of these people, no." And she's talking about the staff. They shouldn't be in and out of our case files because all they do is gossip back and forth. I hear them. They have no respect for our support groups. They walk in and out. When we're having groups, you're not supposed to come in and out. It's no respect here. So let me just say a little bit about class, because it turns out to be quite important. So women, regardless of their class status, were using framing institutions, but middle-class women tended to use framing institutions that were not HIV specific. So they really focused on individual interactions with their pastors and with their therapists to come to terms with their HIV infection, partly because of their desire for confidentiality. Lower income women didn't necessarily have that luxury. In order to get services, in order to get the resources, they have to repeatedly out themselves as living with HIV. So they become much more used to going to HIV-specific social service agencies to participate in the framing process. So therefore, class is offering private and discreet support, but at the same time, it's not allowing middle-income women to interact with multiple women living with HIV. So our low-income women could name multiple people that they knew that were living with HIV. Our middle-income women didn't know anybody else living with HIV, and partly because within their framing institutional experience, it was a one-on-one rather than a group interaction. So finally, we're arguing that framing institutions shape the form and tenor of coping trajectories by offering initial information about health status when you think about that diagnosis experience and why it's so important, a conceptual framework to understand the social meaning of illness when we talk about Jackie's understanding of being around people that helped her understand what it would mean to have HIV, language to talk about one's condition when we think about this idea of people, places, and things that threaten your ability to manage your HIV, and that language coming up again and again in our interviews, and resources to restructure one's life post-diagnosis, everything from housing to bus passes. Framing institutions therefore play a critical role in how women accept their changed health status, manage their disease symptoms and problems, and integrate HIV into their lives. And then you see my final point on the concerns that we have about women who aren't relying on these institutions and the very significant variations that we're seeing in terms of class, in terms of how women are interacting with these institutions. Thank you.
Great, thank you, Celeste, for bringing the patient level into our frame. I'm just going to I have only a few slides here, I promise. Really? But I just wanted to structure the discussion a bit and hope this leads to questions from you. I think what I heard in all these papers today is really this idea that we want to be attentive to the broader social context in which health takes shape. It's really a story of social structure, of organizations, systems, institutions, and this idea that there may be emergent properties of community that are important and that alter the health trajectories that people experience. Celeste talked about meaning making and how that's shaped by the environment, cues of investment, structures that support health-seeking behavior. Some of this reminded me a little bit of work by Sampson and Raudenbush and this idea of seeing disorder in communities and whether some of these cues that might be health-enhancing, people really see and interpret in the same way. Because people talked about social services, I couldn't help but share a few maps here. This is physician density by community. These are the 343 communities that were structured through the Project on Human Development in Chicago neighborhoods. And you'll note that as the proportion poor increases, the number of physicians that are resident in those communities decreases. This really speaks, I think, to all of the papers if you think of the community level, the health services level, and the patient level. And Stacy had said to me in a sidebar, I hope no one asks about why there isn't a level 1 trauma center at the University of Chicago. So I'm helping facilitate that conversation by noting here that there is no level 1 trauma center here at our institution. And also important to note is that there are very few emergency rooms and systems of care of that type on the south side of Chicago. And I think one notion this slide also motivates is the idea that something like a gunshot becomes a homicide when there isn't a place to take that person in rapid manner. And so I'm going to just briefly touch on some key points from the 3 papers. In the Lindau et al. Paper, she really talks about the import of developing a community health research infrastructure, and really asking this question of what is community, and does it vary depending upon the research question? So do we really call upon or want to model the same community when we're thinking about health behaviors like smoking or alcohol intake versus communicable disease? And this idea, too, of science and the service of community, and this made me ask whether our standard model of science and in research on urban poverty and health is actually not oriented toward the community? And does this mean that our framing is different? And finally, do we identify influence through conventional means? Stacy talks a fair amount in the paper about identifying networks of influence. And so this reminded me of a paper by Sampson and Grafe, where we're really thinking about leaders within communities, and actually the results indicate that leader ties seem to be negatively associated with resident ties. And so how do we think about leaders and how they're connected, leaders that may have some influence in the community, how they're connected to residents, and whether that information spreads through the network. I'll turn quickly to David's paper, and he really addresses the import of attention to formal healthcare resources, thinking about excess utilization and inefficient provision of care as key drivers of high spending and poor outcomes, and that healthcare costs and use are highly concentrated among a small fraction of individuals. And this notion of rational reorganization of care that might allow physicians to provide better coordinated care to their patients, and I think Celeste's paper really is a nice link to that third point. And so a few questions for David, really thinking about academic medical centers, and historically they've not had a productive relationship with the communities that surround them. Stacy made this note as well. So how might we alter that dynamic, and how might we think about building new relationships that could change that link? And finally, David talks about these health innovation zones, and low-risk people are really not the focus of the health innovation zones, but what happens when their health status changes, how do we track them, how do we then introduce them into this kind of model, and what happens when they're not the focus of this, and are there sort of lower level kinds of health conditions that in some way would sort of be outside our radar. And finally, the Watkins-Hayes piece I thought drew so nicely on thinking about David's model of health service delivery, and then really where's the voice of the patient, and how do we think about the patient fitting into that, particularly within the context of HIV and AIDS. And she really helps us think carefully about this idea of a framing institution. And I think broadly this merit of an intersection of thinking about organizational sociology literature embedded in that of medical sociology, this idea of institutional ties, stratified social environments, and some of your work reminded me of older work by Angela Rand, thinking about these structural lags and that institutional resources aren't in keeping with changing population processes. And that led me to ask too, what sort of interventions could assist these women? Are there structural components, in the way that Stacy raised in thinking about how we will in some way strengthen the resources at the community level, and David through the service use component, and then at what level of service might be most helpful for these patients. And so, finally, can we imagine a way, as I was saying, that Lindau's resource mapping or Meltzer's health innovation zones would reshape the social environment that these women inhabit? How might that influence the narratives that we heard earlier? And then finally, would that then change the way they frame? Now, there are key turning points, and you mentioned this really at the end of your paper, this idea that there might be changes in that trajectory of illness, and so is there some way that these institutions can intersect to change that course of disease? So with that, I'm going to close. I know I'm supposed to move on to this new slide and ask for your questions.